Mr. President, and members of the Executive Council of the Philippine Urological Association, fellow urologists, ladies and gentlemen, good afternoon. It is indeed a distinct honor and privilege to be the speaker of the Domingo Antonio Memorial Lecture of the 64th Foundation Day of the Philippine Urological Association. Dr. Domingo Antonio was a great professor and legend, dedicated mentor, and highly esteemed clinical urologist. Yet, he was soft-spoken and acts very dignified. He was usually clad in barong. He was the founder of the Philippine Urological Association, together with another known urologist, Dr. Luis Torres. Dr. Antonio was the highly epitomized father of Philippine urology. Let me share with you some of the memorable experiences and encounters I had with Dr. Antonio. When I was an intern in surgery, during a grand round conducted by Dr. Antonio, a case was presented by a surgical resident, after which I vividly remembered the first question of Dr. Antonio to the resident. What is your clinical impression and basis? The nervous resident replied, I believe, for which Dr. Antonio cut him short. Don't pray, just tell us your impression and basis. During my oral examinations of the Philippine Board of Urology, Dr. Antonio was the chairman in a panel of 3. The first question came from Dr. Season of ABM Season Hospital, now the Medical City. The question was, Dr. Abraham, how many TUR syndromes did you have? And don't answer none, otherwise I would fail you because I had several. Dr. Antonio, in his very cool manner, asked this question. Dr. Abraham, discuss how will you preserve the UPJ in doing surgery involving the renal pelvis, such as pelviculotomy or those involving staghorn calculi. When I presented my prospective paper on catheterless retropubic prostatectomy in the plenary session of the Philippine College of Surgeons Annual Convention, I was bombarded, practically harassed with questions coming from well-known urologists. Questions such as, why did you do it? Are you sure you did it? My response was, to prove that it can be done. Other questions were, did you give blood? Did you place a suprapubic tube? One of them stated, please inform me when you have a case, and I shall be there to observe. I accepted the challenge and informed the gentleman that I had a case coming up and invited him to observe. Unfortunately, when I did the case, the urologist came very late. After checking on my patient in the recovery room and seeing that the patient had no catheter, he immediately left. Going back to the plenary session, after I was saturated with questions and remarks, Dr. Antonio, in his usual manner, stood up and remarked, gentlemen, it is the dream of my contemporary, Dr. Ledbetter, to perform a catheterless retropubic prostatectomy, but until his death, he was not able to perform one. Are we not proud that a young Filipino urologist did it? Not once, but repeatedly on several patients. After the plenary session, I approached Dr. Antonio and expressed my heartfelt gratitude for his kind comments. After about 2 weeks, I was surprised to receive a referral from Dr. Antonio with this note. Dr. Abraham, for your evaluation and decision. The patient was a multigravida with previous CS and subsequently a hysterectomy. She had a distal third urethral stone for which I had to do an open procedure. Hence, the case was challenging due to severe adhesions. After a few days, I discharged the patient with an uneventful course. I did not charge her since the patient was Dr. Antonio's niece. My perception of Dr. Antonio, therefore, was that he was very professional, ethical, dignified, and honorable guy, worthy of being the father of Philippine urology. As a clinical urologist, I am very particular about the fundamentals of what I am doing with, and always share this with my subordinates during rounds and inside the operating room and in conferences. I routinely document my findings and assessment and plans and discuss this with the patient and relative. I distinctly remember when I was at the Veterans Administration Hospital in Long Beach in San Diego, California. No less than the chief residents who routinely made the preoperative notes, complete with morbidity rates. In that situation, I learned that if the indication for surgery is relative or a non-surgical option is possible, then the patient should be well informed of his option. Let us deal with our clients or patient with empathy and compassion. In terms of prescribing novel treatments, consider the adverse effects, duration of treatment, and cost, which may affect the patient's compliance. Regarding TURP, don't refer this statement. Kayod lang in order to secure the consent. You will be blamed by the relatives if unforeseen events happen. I describe TURP as a highly technical, highly sophisticated, and highly specialized one-man procedure. TURP is still considered the barometer of a clinical urologist. Hence, one can't be board certified without passing the practical examination being given by the Philippine Board of Urology. Aside from catheterless prostatectomy, my interests include combined suprapubic and retropubic prostatectomy for enormously big prostate, which I refer to as transcapsulovesical prostatectomy. The idea is effective hemostasis and wide access to the posterior bladder neck to do wedge resection to prevent bladder neck contracture, which is fairly common among conventional suprapubic approach. In case of urinary bladder diverticulum which warrants excision, if there is no bleeding, mass or stone within it, I do endoscopic procedure called diverticulotomy. This entails incision of the neck of the diverticulum, followed by application of the roller ball within the diverticulum until ischemia is produced. The resolution of the diverticulum is verified with a quarterly cystography. Innovations are done by forward blocking surgeons who, aside from following the standards and guidelines, think outside of the box. Hence, we have Coker's maneuver for right-sided renal surgery, Burke-Colpo suspension for SUI, Politano-Ledbetter for VUR, and Millen's procedure for BPH, to name a few. During surgery, I routinely ask the residents several questions from fundamental to technical aspects. In case of MIS, if a conversion to open is warranted, one should not hesitate and proceed, or can ask assistance from his peers and consultants. One should not be faulted for that unless there are shortcomings in the preoperative and intraoperative evaluation for which a constructive criticism is raised in a conference. At this point, let me touch on the evolving trends in urology. Urology is one of the most rapidly evolving surgical specialty. This is due to the dual role of scientific breakthrough in the successful combination of engineering and technology for diagnosis and treatment. The role of MIS to surgical extirpation and reconstruction has been unprecedented and very challenging, which both the practicing and future urologists, and of course, the patient will benefit as well. Management of urolithiasis had been revolutionized with the introduction of non-invasive ESWL and endourology in the mid-80s. This has been continued with perfection and miniaturization of endoscopic armamentarium, which has superseded the developments in ESWL technology. The main goal of intervention is to get rid of the stone in a single session, rather than multiple non-invasive sessions in ESWL. Management of renal tumors has also changed significantly over the last 25 years. Traditionally, open surgical procedure was the only option for renal masses. With the introduction of laparoscopic nephrectomy in 1991, followed by laparoscopic partial nephrectomy in 1993, the tumor size dictates the choice of treatment. Tumor less than 7 cm or T1 are usually approached via laparoscopic or routine robotic means. For patients with high comorbid conditions, focal ablation or even active surveillance represent a viable choice. Management of localized prostate cancer underwent significant changes as well. Several decades ago, open retropubic nerve-sparing radical prostatectomy was the standard of care. In the modern world, this had been gradually replaced by laparoscopic and robotic assisted techniques. With robotic assisted surgery, the procedure is performed with the same operative goals as open surgery, like oncological control, preservation of continence, and sexual function. All of these are achieved while enabling the surgeon to work in a minimally invasive manner. The use of new technology in the management of bladder tumor comes into play, like the use of narrowband imaging. This entails the use of a specific blue and green wavelength in endoscopy to enhance mucosal details. This new technique has a greater ability to detect cancerous tissue compared with the conventional white light cystoscopy. One of the most promising evolving procedures in urology is endoscopic enucleation of the prostate, which may utilize different energies such as helium, thulium, and more recently, bipolar energy. These techniques have the potential to replace TURP and open prostatectomy. Although perhaps locally, TURP is here to stay as the gold standard in the management of BPH. Another promising alternative to BPH management is prostatic artery embolization, specifically for men with extremely large prostate, measured at greater than 80 grams or cubic centimeters on ultrasound, CT, or MRI. The objective is to induce ischemic injury which may lead to infarction and decrease in prostate volume. This may be done as an outpatient basis. Let me bring you to a lighter note. Let me touch on a father and son urologist tandem which are currently increasing. Here you will see an example of these tandems. Interestingly, this group of young urologists have met each other during the residency and had been friends, have been brothers ever since. Let me focus on my son Joben, who has a twin brother, a civil engineer. Joben did his fellowship at the University of California, Irvine, under the father of endourology, Dr. Ralph Kleiman, followed by his second fellowship in organ transplantation at the University of Texas under Dr. Barry Cahan. Joben has followed my blessing footsteps and has become a research speaker in many meetings, both in MIS and organ transplantation. I had referred many of my patients to him, particularly those who are for endoscopic stone management. In those cases, I ended up being his student as he teaches me the operative steps, giving me tips and tricks during the procedure. On the other hand, when Joben has a procedure for TURP or open prostatectomy for enormously big prostate, he would ask me to do it with him as the mentee. He liked my modified procedures or technique, and later he has been doing them without me. In these situations, there are no fees involved, only gifts which are well received with love and gratitude. I am very proud of him. This is a question my son has always asked me, Dad, can you still learn and are willing to do PCNL? To which I replied, of course, especially if you are my mentor. Here you see me doing a PCNL under his supervision. In summary, no procedure is absolutely safe. Unforeseen events do happen in the best of hands. Take care of your clients or patients with care, compassion, and charity. Remain updated on the evolving diagnostic and therapeutic modalities in urology. From Dr. Domingo Antonio, in his comment on the arrival of ESWL in the Philippines, the practice of medicine should always be tempered with a gift of charity and generosity. Thank you for your time and kind attention. Good afternoon, stay COVID-free, and God bless.